let's talk about bones that pertain to the respiratory system. So one of the first things we need to talk about is the spine. So you can see that the spine is made up of, you might know this already, the spine is made up of different individual small vertebrae, right? And each of those, they're grouped into 5 different main sections. 3 of those sections are not fused, and so those are the ones that we're going to focus on. Towards the top, you've got your cervical vertebra. There's 7 of those. And then moving down, you've got thoracic vertebra. There's 12 of those and 5 lumbar vertebra. Below that, you've got the sacrum, which is made up of 5 completely fused vertebrae, and then you've got the coccyx, which is made up of 4 fused vertebrae. So they're fused, so it's not as important, certainly for this class, to know about those. I mean, they're below where we care about things as SLPs anyway. So we'll focus on the top ones here, the cervical, thoracic, and lumbar. You will need to know these on the exam. So, I mean, not like each one, not like particular characteristics of each individual, all of them, and be able to identify them or anything crazy like that. But you will need to know the order and how many of them and things like that. The best way that I know is breakfast at 7, lunch at 12, and dinner at 5, right? So you've got 7, 12, 5. But then when I was teaching this on ground last semester, my students were like, yeah, but that doesn't tell you which one, what order they come in, so you should figure out, we need to figure out the way to, do this. And so then you have to think about what you're eating, right? So you have cereal for breakfast at 7, and then you have a nice taco lunch, some tacos at 12, and lasagna for dinner at 5. So cereal at 7, tacos at 12, lasagna at 5. C for cervical, T for thoracic, and L for lumbar. Hopefully that works. All right. So let's talk more about the spine. Something that's really interesting about as you go down the spine, look at each vertebra down the spine, is you see this kind of inverse relationship between the vertebral foramen, which is right here. Remember, foramen means hole, to bore a hole, but it's a hole. And the vertebral body, which is this more osseous structure back here. Osseous meaning, pertaining to bone or bony. So osseous would be a bone structure. So you see the inverse relationship between the two. If you look here, this is the C1, the very top cervical vertebrae that interfaces with the skull. It's got a huge vertebral foramen, right? There's hardly any vertebral body at all. I mean, sort of here you could say that's sort of where the vertebral body would be, but it's got a huge vertebral foramen. Looking over here at the other cervical vertebrae, you've still got a large hole. You're starting to get a bigger vertebral body. Moving down to thoracic, this is smaller, this is larger. At lumbar, the vertebral foramen is pretty small. The vertebral body is huge. And then as you move down, you just, the vertebral foramen tapers into nothingness. The vertebral foramen is where the spinal cord goes. Right, so this is what makes up the encased in bone portion of the spinal cord. That's what keeps it as part of the central nervous system and not the peripheral nervous system. Why do you think the vertebral foramen decreases in size? Why does the spinal cord decrease in size as it moves down the person? Think about that for just a second. It's because at every layer, there are more nerves that come off of the spinal cord, right? So as it passes through the cervical vertebra, nerves are branching off, and there's nothing that's taking up that space. Nothing needs to be there because really it's just conveying information, say, from the end of my finger on up and up. It doesn't need to convey information from my hand down to my leg. So there's no reason to have connections between the hand and the leg. All the connections are coming up through the spinal cord to the brain. So that's why the spinal cord decreases in size. That's why the vertebral foramen decreases in size. Why does the vertebral body increase in size? Well, it just, everything is weighing on top of these vertebrae as you go further down. Every layer, there's more weight that's being put on it. So it increases your ability to hold the weight of the body and things that you lift and all sorts of things. And taking in, shock when you jump on things as well. So if you didn't have a larger if you kept the size of this vertebral body here down in your lumbar vertebra, it wouldn't be good. They would fracture much more. They'd fracture much more easily. Yeah, much more easily. And so then the C1 up here, like I said, this is important. You can see how large the vertebral foramen here is. You've got like the entire spinal cord is sitting here. The entire spinal cord, all of the nerves are flowing down through the C1, except for the cranial nerves. So there's a couple things that are important here. You can't really see what it says here, but this says transverse process right here. That's this osseous process off the edge, the transverse process. That's important. We'll talk about it more later, but all of the vertebrae have this transverse process. You can see it here. This is the transverse process up here. This is the transverse process on the thoracic vertebra. This is the transverse process on the lumbar vertebra. The sacrum and the coccyx kind of have, these wing-like things on the side that are analogous to a transverse process, but again, we're really only going to be focusing on these three here. So this is the transverse process. You'll see why that's important in a second. One last thing is you've got this transverse foramen here in the cervical vertebrae. That is where blood flow is coming up towards the brain. So it moves through this hole right here. It's protected a little bit from being jostled around or being injured in some way by traveling through the transverse foramen. So that's where your blood flow is housed. All right. The C1 is also important because it is the major point of contact between the skull and the spine. And the C1 is structured in a way, it's got these large facets here that keep the head from rotating too much. So it'll, stop the head from turning too far this way or this way. One thing that you see a lot of in car accidents and stuff like that is something called internal decapitation. If you watch Grey's Anatomy, I think one of the early seasons has somebody that ends up getting internally decapitated. It's not external decapitation, like the head doesn't come off. It's internal decapitation because the skull is no longer connected to the rest of the body. The C1, it says atlanto-occipital dislocation. That's the proper name for internal decapitation. So occipital, meaning the occipital bone of the skull, which you'll learn about when we get to the bones of the skull, but it's this bone right here that comes down and then interfaces with the spine. That's the occipital bone. It covers the occipital lobe, which remember is at the very back of the head. So it covers the occipital lobe and then also moves down and covers the bottom portion of the skull as well. So the occipital bone is dislocated from the atlas, the C1, and that's why it's called internal decapitation or atlanto-occipital dislocation. Again, that happens a lot with like extreme whiplash injuries from car accidents and things like that, airplane crashes. You can survive it. If you've seen the Grey's Anatomy episode, you know that guy lived for a while. I'm not going to give away what happened to him in the end. But you don't always live through it, right? So about 30% of the cases are non-fatal, but those non-fatal cases need to be treated immediately, immobilized first, and then treated to artificially attach the the skull back onto the spine until healing can take place. But healing is a sort of a long process of that kind of injury as well. But anyway, that's the atlas. Okay, so probably should have put this slide a little earlier, but the spine is the major anchoring point for all rib cage movement. And you can see on this guy over here that, I mean, it's true that really the spine is the only thing, the only continuous osseous structure that makes contact with your hips, which makes contact with the ground, right? So everything above this line right here kind of depends on the spine as its main point of contact. The spine is bolstered by a whole bunch of muscles, and we're going to talk about those muscles next week, at least the muscles that are important for moving the rib cage and breathing. There's a ton of muscles throughout the back and the thorax that make it possible for you to do, you know, everything that you do with your upper trunk and your head. But anyway, again, it's the major articulating nexus for everything. Certainly for the rib cage, which is what we're focusing on right now. You've got this kind of frame, kind of a triangular A-frame structure that's formed by the scapula. The scapula is this here. It's this large. You can see how absolutely large this bone is. You can feel it in your back as well. It's your shoulder bone here. You can see that it's covered by a lot of muscle, but you can kind of feel it. If you're double jointed, you can feel it really well. If you're not double jointed, you might have to move into a strange position, but your scapula is one of them, especially the upper portion of your scapula. The clavicle, which you can feel up here, this is your clavicle right here, also known as your collarbone. The spine, and then the sternum, so the clavicle comes here and connects to the sternum right here. And then your scapula is back here. So these are going to create this kind of A-frame structure that helps support itself. You've got all these, you know, pressures kind of pushing against each other to make a nice support system. And then the rib cage hangs from that A-frame support system. You can see here you've got clavicle, clavicle, sternum, and then scapula here in the back. So this is going to make contact with the scapula. This is going to make contact with the scapula here. They make contact with each other there. So like I said, there's a lot of strong muscles that are kind of helping support this structure. This is the only singular slide about muscles. It just kind of fits in right here. The erector spinae group is going to kind of work against, you know, all the forces of lifting the rib cage to kind of solidify everything moving up the back. What you need to know is erector spinae group. The erector spinae group can be broken up into the spinalis, the longissimus, and the iliocostalis over here. These three different muscles, and you'll have those on both sides as well. I'm not going to ask you about those three different ones. If you're interested, here they are. But what you need to know is that those three form the erector spinae group, and they're going to work against all of the movements of the rib cage. When I say work against, I don't really mean that they're like antagonists to that movement. I mean that they're going to kind of provide structure so that that can all move. They're going to rigidize the back so that the rib cage can move. Totally lost a word there for a second. All right, so here's the sternum right here. This is actually broken into two parts. You can kind of see that right here. There's this slight break. So you've got this manubrium. This is right here. First of all, I think the sternum looks like a necktie, right? It just looks, you know, it's like you're perfectly well dressed. If you could take off your skin and your muscles, you've got a tie going, so you could be a waiter at any fancy restaurant. So anyway, the manubrium here, it means handle. I guess it kind of looks like a handle. It definitely looks like a knot, the knot portion of a necktie to me. Though I guess the people who named this back during the Renaissance probably didn't wear ties, unfortunately. Ties are great. It's a connection point for the clavicle, which you can see here. And then you've also got these two ribs up here that are going to connect to the manubrium as well. So actually the second rib is going to connect partially to the manubrium and then partially to the sternum proper. The top rib here is going to connect only to the manubrium. It says sternocostal cartilage here. This is true. You can see that for these ribs, this is it's called the osseous portion of the rib right here. That's the bony part again. And then you've got this cartilaginous portion right here, which is blue in this picture for whatever reason. Cartilage isn't blue. But I guess it highlights the difference. So you can see that that's where the cartilage connects. The cartilage is going to connect to the sternum, from the ribs to the sternum, throughout the entire sternum, throughout the entire rib cage. But 1 and 2 connect to the manubrium. All right, so then you've got this portion of the sternum here. This is called the gladiolus. It means sword, so that's interesting. I see that I say means sword too. That actually should be down here because ensiform means sword also. This xiphoid process. We'll talk about that. I've got it slightly out of order. Anyway, this gladiolus here, like it says, it connects ribs 2 right here, which again connects to the manubrium as well, through 7. 2, 3, 4, 5, 6, and 7 comes up and connects to the end of the gladiolus. So 2 through 7 are going to connect to the gladiolus. 1 and 2 are going to connect to the manubrium. Like I say, it means sword, but then that's kind of ridiculous because you've got this point at the very bottom here. So this kind of like tender portion of your sternum. Again, you can't see what I'm doing. It's kind of right here. This is the part that kind of, like up here you can push on the sternum, no problem. The xiphoid process or the ensiform is kind of touchy. If you push on it too hard, it's kind of painful. That means sword as well. So you've got 2 things that mean sword in the sternum. Interesting. And the ensiform is essentially just the tip of the sternum. And it's an attachment point for both the diaphragm and the abs. So that is going to be, remember, the diaphragm is very important. The abs are also important for exhalation. And that's a big attachment point for both of those. The diaphragm connects kind of on the inside of the xiphoid process, so not closer to the outside of your body. The more proximal portion is where the diaphragm connects, and then on the outside, the more distal portion, that's where the abs are going to connect. All right. So here you can see that you've got these true ribs, 1 through 7. Did I not correct? Ah, darn it. Okay. So 1 through 7 are true ribs. 1, 2, 3, 4, 5, 6, and 7. Remember, 7 is the one that connects to the actual sternum, the gladiolus of the sternum. So 1 through 7 are going to connect directly to the sternum. Those are known as true ribs. This says 7 through 12. It's actually 8 through 12. Those are floating ribs. You're going to have 2 different types, right? So false ribs, like I say, 8 through 12. But some of those, 8 through 10, are going to connect to rib 7 right here. They just kind of come up and connect to the cartilaginous portion of the rib above. And then 11 and 12 are floating ribs. They don't connect to anything. This right here, this is the xiphoid process, or the ensiform. You can see it a little bit better in this because it doesn't have the tendon attached to it like I did on the last picture. Here I did correct it. It's false ribs 8 through 12 like it should be. And then also I forgot to mention that some people have 3 floating ribs on each side and some people only have 2. For everybody, it's 11 and 12. For some people, 10 can be floating as well. It doesn't really, it's different variations in different people. And then also, some people can have an extra cervical rib at the top. It's rare, and you can kind of see it right here and here. You get this weird extra cervical rib. So cervical meaning at the top, not at the bottom. It's more common in women. I'm not sure why. And it's not a great thing to have because it can actually push on both the blood supply and the nerves that kind of move around the clavicle here. So you've got the clavicle is this right here. You've got nerves and blood supply that they come out of the spine and they move down through this region. This extra cervical rib in some people and after time, right in this area right here, can start pressing down on the blood supply and the nerves. So the first thing that's going to happen is the blood supply will be reduced a little bit, but you won't necessarily notice that. What you will notice is tingling as the nerve starts to become depressed. Well, that's not good, but what's worse is that by the time you're noticing the tingling, the blood supply is diminished a little bit more. It's not to the point where you're like running out of blood to your extremities, though it could eventually get there. But it's tingling and you're running out of feeling in your fingers because the nerve is being cut off. Messages from the end portions of the nerve can't make it through their axons to get all the way up to the spinal cord and then all the way up to the brain because it's being occluded right here. So it's not a great procedure to have. Luckily, you can have them surgically removed, and sometimes they don't even have to be completely removed. They can just be kind of like roto-rooted out to make a larger area for the nerve and blood supply to go through. Anyway. All right, so this is how the ribs are going to connect to the spine. Each rib, ribs are extending from the taco vertebrae, right? And they're numbered in association with the thoracic vertebrae. So you've got T3 is connected to the third rib, right? So your third thoracic vertebrae is where the third rib connects to. So that makes some sense. But you'll notice that each rib actually connects to two vertebrae. So it's not necessarily that the third rib only connects to T3. The third rib is going to connect to T3 and T2. You can see here that this is the transverse process here. Remember I said that was going to be important later. So this is the transverse process. It's from a slightly different view, so you can't tell that it pokes out to the side like that because we're looking at it dead on. But that's what it's doing. That's that transverse process. So the rib's going to connect to the transverse process of the thoracic vertebrae that it corresponds to. It's also going to hook onto this right here, which is the superior costal facet. Superior meaning top, right? Costal meaning rib, and then facet meaning connection point. So it's the superior costal facet. So it's going to, the rib, which like this, it'd be this one here that has been taken away so you can't see it. This rib is going to connect to this transverse process to this superior costal facet. But then it's also going to connect to the inferior costal facet of the vertebra right above it. So the first rib is actually going to attach to the inferior costal facet of the last cervical rib too. So 3 connection points. You should probably know those connection points. All right. So you have some interesting issues with your ribs. Remember we talked about the thoracic cavity is under stress from pressure change, right? So the thoracic cavity is made up of the rib cage and the diaphragm here, and the lungs are inside the thoracic cavity. right? So when you breathe in, the diaphragm moves down and it creates negative pressure in the thoracic cavity. Well, what happens if you have broken ribs? So the ribs are there to provide structure for the thoracic cavity, right? So it can have negative pressure, and then the only thing that's going to happen is the lungs inflate. Because if the rib cage is intact, it's holding the fort, and then the lungs will inflate to take up that space. But if you have broken ribs, not necessarily just broken ribs, but you can see here that this is called flail chest. These are actually ribs that are broken in two sections. If you have a rib broken in one section, it'll be painful to breathe. But that broken section will actually just kind of press against itself. Again, very painful, but it won't necessarily do this flail thing. But if it's broken in two sections, then it's kind of like, so you've got, here's part of your rib, here's the broken section of your rib lying between the two broken parts, here's the other end of your rib. So then when it's under negative pressure, instead of pushing against itself, this part will just move in. And that'll create a lot of pressure, a lot of pain. But it also causes problems with breathing. So if you look at this right here, the diaphragm moves down. It's trying to expand the thoracic cavity so the lungs can expand. But what happens is that flail chest portion kind of deflates in to take up the space. That's not good. We want the lungs to inflate to take up that space. We don't want the outside of the thoracic cavity to fall in and collapse on itself. And then you can see that when you breathe out, the diaphragm moves back up, and what we want is the lungs to collapse, not all the way, but collapse somewhat and force the air out. But when you have this flail chest, it kind of pooches out to the side, and then the lungs don't get deflated all the way. So in addition to being extraordinarily painful, you're also not being able to take in as much breath as you want or push out as much breath as you want. So you're in pain and you're short of breath. Not so great. All right, that's the end of the lecture on bones. We're going to talk about airways in the next lecture, and then that's it for this week. We'll talk about muscles and clinical issues next week.